All right. Well, good afternoon, everyone. Thank you for being patient through the technical difficulties. Really excited to be here today for this panel. My name is Fulgencio-Turner. I'm the director of the Climate for Health program at EcoAmerica. And so for those not familiar, EcoAmerica is a national nonprofit. We're a nonpartisan organization focused on building the social movement for climate action. And we do that by engaging the most trusted voices in local communities that can connect with people on their priorities and values. So we have a faith program, communities and civic associations program, and then I direct the health program. And we're also a very, very proud co-host of the Our Planet, Our Health conference, along with the Medical Society Consortium on Climate and Health, American Public Health Association, National Academy of Medicine, American Lung Association, Planetary Health Alliance, and Physicians for Social Responsibility. So really, really proud to be part of this group. And again, excited about this panel about bridging the gaps on educating health professionals on climate change across different specialties and across the scope of folks' careers. And one of the great things about having that extremely long list of co-hosts for this summit is that we have a really diverse gathering of health professionals, just people from all different types of fields, from nurses and physicians to public health to researchers and educators, going all the across, again, from very, very early career all the way through to health leaders that are renowned in their fields. And we know that across this entire spectrum that we desperately need more education on climate and health. I do trainings. One of the things that the Climate for Health program does is a Climate for Health ambassador training to get people connected on over the hump of how climate change impacts health, that it is part of their work. And one of the things that comes up constantly in these trainings, no matter whether I'm talking to social workers or clinicians or health department directors, are these kind of common refrains of just not really my problem, outside the scope of my work. This is one big extra thing, it's too political. And so getting people over that hump, getting them to see that this isn't something extra, that this is not something outside of their job description, is a necessary first step to have any kind of engagement from the health sector on climate action. And so you all are here, I'm preaching to the choir here. So what we're talking about now is not to convince you all of that, but to talk about the ways that we can educate health professionals. And we have an incredible panel I'll be introducing in a second that have real world examples of how this works. And again, this is important because we know it's not just true from that anecdotal data of going out and talking to your colleagues. EcoAmerica has done extensive polling of the public and of health professionals specifically on their attitudes about climate change. And it is the vast majority of health professionals see climate change as a significant priority, but aren't sure what to do about it, don't feel confident taking action, not sure how to fit it into their professional and personal lives. And when we poll the general public, the vast majority of people are concerned about climate change, but think that nobody else is, that think that they're alone in their concerns. And so this phenomena of pluralistic ignorance is an incredibly powerful one. Feeling incorrectly that you are alone in your beliefs isolates people. It makes you feel like, why even bother? I'm just gonna get shouted at. I'm gonna have to have a fight every single time I talk about it. And the ignorance part of this is that it's not true. That you're gonna be pushing on open doors a lot more than you think, and especially when you have the kind of tools to connect with this in a productive way that engages people on solutions and action. All of that to say that we are really excited about breaking that bubble. I know, again, everyone here preaching to the choir. What we need to do is figure out how to have that multiplier effect of working through your networks of health professionals and colleagues and friends to get them doing the same thing, of breaking people out of that bubble of pluralistic ignorance so that they feel confident and comfortable talking about climate change and can talk about it in terms of solutions and actions that are real and local and active. And so again, this is why we are so excited for this panel. And I'm hoping that leaving here today that you all will leave with both inspiration and examples and ideas to take back to your homes to implement and build on and grow. So I had to pull up the bios to do my quick introductions, so apologies. But I will just quickly introduce all three of our panelists before I hand over to them to speak. So first off is Dr. Beverly Malone, who is joining us virtually. I will pull her up on the big screen when we hand off to her. Dr. Malone is the president and CEO of the National League for Nursing, where she advances the science of nursing education through enhancing stakeholder collaboration, increasing diversity in nursing scholarship, and championing evidence-based practice. Dr. Malone's career has blended clinical practice as a nurse, education, administration, and policy, including serving as Federal Deputy Assistant Secretary for Health. She was elected to 2 terms as president of the American Nurses Association and served as the first African-American General Secretary of the United Kingdom Royal College of Nursing. Dr. Malone has been deeply engaged on climate action, co-leading the National Academy of Medicine's Health Professional Education and Communications Working Group, and we're very proud to have her as a member of the Eco-America Climate for Health Executive Committee. Sarah Brown, here today, is the Climate and Health Project Specialist. The Climate Health Project Specialist for New York City Health and Hospitals, which is the largest municipal healthcare system in the US. She works within the Central Office of Emergency Management and system-wide special pathogens team to strengthen climate resilience, and she leads initiatives ranging from environmental education to emergency communications and vector-borne disease tracking. This on-the-ground work focuses on the intersection of preparedness, public communications, and physician engagement and education. And I'm really excited to hear more about how health systems are leading in this space. Dr. Cheryl Holder, also here with us today, is the Executive Director of Florida Clinicians for Climate Action. She is a physician, educator, and climate health advocate dedicated to improving the health of underserved communities. She's a graduate of Princeton University and George Washington University School of Medicine and a National Health Service course scholar, internist, and HIV specialist. She served as the medical director of one of Miami's largest community health centers and contributed to providing the community voice through advisory roles with the NIH and CDC. She has served as the president of the Florida State Medical Association, co-chair of Miami-Dade Heat Health Task Force, and was associate dean at Florida International University's College of Medicine. Her work advocating for climate solutions and educating a diverse range of health professionals and the public and communities is incredibly creative and deeply impactful. So really, really impressive panel that we have today. And without further ado, you don't need to hear me talk anymore. I am going to ping over and make Dr. Malone full screen. If you are able to jump in, Dr. Malone. Oh, I think that, let me see if I can unmute.
I think can you hear me now?
Yes.
And see me. Thank you very much, Ben. Much appreciated, colleagues. I'm sorry I'm not able to be there with you. I thought I would start out just by talking about my conversion, because I was one of these sort of dancing through the world of nursing without understanding climate and its implications for nursing, that it is a healthcare issue. And it took me a visit out in the desert with nurses who are all committed to climate to shake me enough to understand that this was about 10 or 12 years ago, that I started to realize I can't be a nurse without understanding the power and the issue of climate and the environment and how it affects the daily lives. Healthy planet, healthy people was really my calling that woke me up. So how do I look at it? I look at it as just a natural part of nursing, that there's no way I can talk about healthcare. There's no way I can talk about anything to do with the mission of the National League for Nursing without understanding climate and its implications and the environment. So my mission, our mission for the National League for Nursing is promoting excellence in nursing education, to build a strong and diverse nursing workforce, to advance the health of the nation and the global community. So what am I suggesting there? That if your mission is really what's driving you, is that your North Star, then climate has to be part of that. Realizing that mission, it's not an add-on, it's not instead of, it is about, that's the only way to meet your mission is for climate to be a part of it. The second part, we have core values that underpin our mission, and those are caring, integrity, diversity and inclusion, and excellence. And so I want to talk to you about caring, which is promoting health, healing, and hope in response to the human condition. So you can see how climate fits into that. The patients we serve, those who are frequently the least ones given care or having the access to care. All of that's important. And then the excellence is co-creating and implementing transformative strategies with daring ingenuity. And to me, that's what we have to do in terms of this issue around a healthy planet, a planetary health. And so I'd like to share with you just very briefly some of the things the National League for Nursing, because it's one thing to think about it, dream about it, but a vision without action, colleagues, is a hallucination. And so we really need to be not just thinking what we're going to do, but doing it. We started out by actually giving an award to a school that had done just incredible work, University of Minnesota. Teddy Potter is out there. She's fantastic. And the work that they were already ahead of the game. And the NLN, the National League for Nursing, 130 years old, gave an award to say, look at this, colleagues. We followed that up with the understanding that it needed to be something continual and sustainable. And that is to make sure that it is one of the centers of excellence for the National League for Nursing. We have centers of excellence for learning, for teaching, but now we have a center of excellence dedicated to the environment. And that means that there's a whole process in terms of getting there. You have to have a consultant who works with your school. You prepare your application. It's a document, and it is a competitive process. And then you are assessed and decided whether or not you meet the criteria, and you become a NLN Center of Excellence for Climate. For a healthy environment is what we call it. So this is the first year we'll be doing it at the 2025 NLN Summit in Orlando. And I'm just very, very excited about it. I can see we are so competitive. Nurses are really a very competitive group of people. So I can just see the competition rising among the schools and more schools coming on and working to become a center of excellence for a healthy environment. So that's one of the things we do. The other thing is we do vision statements, and I believe in dreaming and, the vision piece, and I also believe in the action piece. So we have the dream of what we want to do for climate. Now, how do we make that happen? Well, one of the things we did was to put together a vision statement. We brought around experts around climate, and they put it together. Following the vision statement comes a toolkit that is actually a prescription for how you can integrate it into your curriculum. Because we don't know where to start frequently, and we have enough in our curriculum. I mean, if you're in schools of nursing, that's what it's packed. We can't do another thing. So we want a step-by-step process to make it as easy and simple as possible, to have consultants available to help you do this, of how to integrate these issues into your curriculum. So it's a toolkit. We then do articles and establish research endeavors all around this area. And that's how we integrate it into the entire system of nursing education. I'm so very delighted and pleased to say we are on that journey. We've already got the mission statement. We are working on the toolkit. We do virtual online courses about it. And so we are becoming identified as someone who is there to support and acknowledge nothing but making sure that climate and healthy environments, healthy planet, healthy people. Thank you so very much. I turn it back over to you, Ben.
Thank you so much, Dr. Malone. I will say that before I hand off the mic, incredibly inspiring, creative, and clever to harness that competitive energy that we all see among nurses and push it towards that driving towards having competitive climate centers for climate excellence, or excellence for a healthy environment. So really excited to see how that program grows in the future. So we will have time for questions at the end. For folks online, also everyone can submit questions through the CVent app, and I'll be reading those off. And then for folks in the room, we can read them. I just need to read them into the mic as well. Great. So I think next up is Sarah. So I can drive the slides. I'll just hand over the mic.
Thank you so much. Hello, everyone. I'm honored to be here today. That was an incredible talk. And we'll also talk about a toolkit. Perhaps we need to somehow morph them together, but I'm Sarah Brown. I'm a climate health project specialist at New York City Health and Hospitals. As Ben said, I work with the system-wide special pathogens program and the Central Office Emergency Management teams. And just a brief overview, how does climate health fit into that? We have 3 buckets. We work on resilience. That's mostly through disaster planning, emergency preparedness. The second is research. That's mostly on the specific climate vulnerabilities of our patient population as a public hospital system. And the third is reduction on carbon. And we sort of believe that you have to be working on all 3 of those, or it's best to be working on all 3 of those to really make an impact. And we're the largest, essentially, public hospital system in the nation. But today, next slide. Today, I'm going to talk to you about one of our initiatives. It's an educational one. It's called Climate Health Champions. And essentially, we're training clinicians, nurses, physicians, community health workers, anyone that works with patients, how to talk about the specific health needs of their patients through a climate lens. So this is really trying to approach it from a granular lens. For example, you're thinking about asthma and air pollution. That's the classic one. But also, we know you have a higher risk of preterm and early term birth with heat events. So how can we have sort of these key insertion points for conversations that are already happening with physicians and nurses and healthcare professionals, but bring in that climate angle, or at least the climate risk angle, if you can't actually say the word climate change. Okay, next slide. So this is the overview of, and I also need to mention, this toolkit is publicly available. We are partnering with hospital systems across the nation, and we've actually expanded internationally as well. I'll explain it, but you can put in your own local risks. You can adapt it to your health needs for whatever situation you're in. So definitely reach out if that's something that you're interested in. But for our overview, what can our listeners do? They can speak with their patients, and we're going to sort of arm them with the information that they need and the entry points that they need, and empower them to be advocates more broadly. And it's modeled after our Be a COVID-19 Vaccine Champion initiative, in which we mobilize these personalized conversations to help to bridge that trust. The data sort of shows that human-to-human connection has the ability to really change behavior in ways that other messaging cannot, or cannot really speak to that emotional side of things. And I think we've been hearing about that today. So that's sort of the lens that we're trying to take with this initiative. So what is the initiative? There are 3 components. We have a 1-hour training. It can be inserted easily into a forum that's already existing. We have a detailed handbook that goes through all of these different sort of conversations. What are the entry points? How can you ask questions? How can you explain the why? I'll go through that a little later. And then we really believe that you need to sort of empower people to take those next steps, to make that commitment, to feel like they have enough information already, and that they don't need to sort of be an expert. Next slide. And so just for a little bit of background, we had an incredible advisory committee with physicians who are leaders in climate and health, with nurses, with a patient advocate, with an environmental justice leader. So I just wanted to bring that up, that these materials have really been shaped by some of the experts in the field. We wanted to make sure that they were as impactful and accurate as possible. Next slide. So what are some of these barriers to actually having these conversations? Perceived barriers is what I should say. The first is that there's no time. So we've really sort of molded these materials to fit within conversations that are already happening. So you can just sort of mention every time you're prescribing an inhaler, you could also mention we need to be looking out for the air quality. Every time you might be prescribing a medication that could dehydrate someone, could we think about what does that mean for heat days? How do you monitor your urine to make sure that you're actually being hydrated? So the no time, we really train people that this might not actually take that much time. You have enough information. Let's think about how to most easily insert this into the clinical conversation. The second is people are unsure of the impacts. I've already talked about this a little bit, really empowering people that they know enough. And here's where you can find more information if you feel like you need it. The third is a perceived lack of hospital or peer support. And by having this training integrated into hospital systems, we hope to sort of counter some of that. So by having it at New York City Health and Hospitals in our own hospital system, we're saying these are the conversations we sort of want you to be having. And then the peer support, you can look around the training and you can see, I have peers here that want to be doing this as well. And then a perceived lack of patient interest. This is actually an Eco America survey. There was approximately 70% of patient trust, and patients trust health professionals for climate change information. So really just sort of educating the people that are listening that there might not actually be this lack of patient interest. This might not actually be necessarily as divisive as one might think. Next slide. So just going to go through the 3 parts really quickly. The first is the training. Next slide. There are 4 components to the training. The first is broad climate health impacts using sort of a CDC framework, or what used to be the CDC framework. Part 2 is local specific risks. So we talk about New York City specific risks. In our toolkit, we have a sort of a section that you put in your own locality specific risks, whether that be coastal flooding or heat days, or sort of like the urban heat effect if you're in a city or otherwise. The third is how do you have these conversations? And the fourth is additional resources. Next slide. So here is an example of one of our slides on heat. And there's a lot of information on this slide. But as you can see from the orange letters, we're not saying everybody should do everything. We're saying here are some options of things that you can say to your patients, how you can help them. And then we encourage them to reflect on which of these resonates with you, which of these could you actually see yourself bringing up with the patient. And then can we put that in the chat? So we really want to make sure that this training is as interactive as possible. So just to give you some examples, we have a heat action plan if you have maybe a little bit more time, if you're the kind of clinician that has that. So the heat action plan, and you can see this one specific to New York, but we can make them specific to any city, any locale. And educating people about checking their urine color, educating people what sort of resources are available. So in New York, we actually have a cooling assistance benefit where you can link people in to get ACs, to maybe get some financial support to cover some of those energy expenditures, and then educating patients on what symptoms to look out for if you're a pregnant woman or a pregnant person, and you're in a heat event. What are the signs that say you need to go see your doctor right now, or you need to reach out to a health professional? So you can see there's quite a lot of different things here, and we go through a whole series of risks. This is just one example. Go to the next slide. So the second, we have a handbook. We can go to the next slide. And so here's an example of one of our double sheets on the handbook on heat once again. So we have a format we've set out here, and we're not saying you have to follow this, but here are some ways that you could engage with this conversation. The first is a question, say there's somebody there, maybe for heat illness. I'm going to read the third bullet point. If you're getting too hot at work and you are starting to feel sick, do you know some things to look out for? What are those symptoms? And then we know that the data really shows that if people can understand why their body might be reacting in that way, they're much more likely to change their behavior. So simple how or why. In heat, your body has to work harder to stay cool. This can make it harder to breathe and put extra strain on your heart, right? Very simple. You can understand it. The third is to strategize a plan. If you see blank, what do you do? And then additional resources in case people want to find out more. So once again, we have sheets like this for quite a few different climate-related risks. Next slide. And so then from there, we essentially want people to feel like they have the competency, like they have the information. So we really want to have, you're certified in this. We give out a certificate. And then we try to help people make a commitment to engage 3 patients. And maybe those 3 patients will be pretty challenging at first, because we know everything you're doing for the first time is challenging. But if you've committed to doing 3, maybe the first one's really challenging, and by the third, it feels a little bit better. And as you can maybe see in small text here, we want you to engage them in the way that feels most simple to you, that feels most in line with your clinical style. So to write a list of the ways that you might have remembered from this training, and then from memory, and then maybe supplement with the resources, and then think, yes, when I'm prescribing blank, I will do blank. And then you have sort of a game plan to go forward. So once again, thank you so much for having me here. I was really excited to talk about this initiative, and definitely happy to talk to anyone that wants to hear more later.
And I'll just say I am incredibly excited that a big health system, one of the biggest municipal health system, has adopted this and co-signed this. I will just share for anybody working at health systems, it's incredibly, like we were talking about competition and the drive of nurses, health systems also get pretty competitive. They also need a permission structure to engage in this kind of work. I've spent a lot of time with health systems trying to get them to do more provider engagement and training like this. Incredibly exciting to see the health system owning it and taking it on, and also something that you can take back to your health systems and say, why not us? Why aren't we doing this? They're already doing it. Are they better than us? Are they more out? Yeah, this is something that can really help to drive, be a wedge, be a leverage point for you to drive that kind of action. I'll get off my soapbox and hand it over to Dr. Holder. Yeah.
Oh, you didn't load them up? Okay. I'll start while he loads the slides. I'm Dr. Holder. I've been with Florida Clinicians for Climate Action since 2018 when Dr. Mansal and I know if he's here, we started the organization. And we've really focused on clinician education, but we also develop ways to get the education in the community. We link with medical students and created a community practicum, and we do quite a bit of advocacy work. We're in South Florida. Heat is number one. We have an incredible alliance that we've developed starting under a Kresge Foundation grant and some of the advocacy organizations, which brought a groundswell of the community because we surveyed the community, we pushed the community to tell us what is your number one factor that you feel with the climate. And the community said heat. The government had been saying sea level rise, but with our survey and our working as a collaboration of multiple organizations, we're able to elevate heat. And we got the first heat officer in the world, and we got a blue mayor who then gave a heat office. Unfortunately, things are changing. But with that heat office, we developed a heat action plan. And that's where Florida clinicians, since we've been there from the beginning, we see ourselves, and this is what we try to brand FCCA as the first stop when you come to Florida for climate and health. We don't tell you what to do, but we want to work with you in developing where your action items are. And then we develop the resources of collaboration to make this work. Like we said, who was said about being delusional and hallucinating? Well, we don't want to be delulu, as the kids say. We want to make sure that the action comes to fruition. And with that, I don't know if you've got it yet, one of our big areas, is prenatal, low birth weight, maternal health. For every degree rise in centigrade, you have a 6% increase in stillbirths, and this is just worldwide. When you look at the populations, it is low wealth communities. We just looked at this problem and we are at grassroots. So when we looked at which clinicians are most in touch with that population, it was the doulas. And at the same time as doulas became more popular, our local safety net system, through funding with another foundation, again, we use a lot of collaboration. The Health Foundation started funding doulas for training and linking them with our safety net hospital, Jackson Health System, and they're going to be placed in the high risk OB sections. So we felt that was the best group to then turn them into climate educators. And they are paid by Medicaid, if they ever get the funding, for 3 visits. So we looked at how can we leverage those 3 visits and supply more visits in these vulnerable communities with these doulas, because they're going to get the highest risk population. So we looked at the processes. Now, well, how best can we train our doulas? Florida, we already have what we call climate and health outreach teams, which we developed in 2022 using a 4-hour virtual training system. And we train high school all the way up to go in the community about heat. And similar system like what you just saw, we built similar structure. It's very specific to Miami-Dade County. We use all the Miami-Dade County resources, and we have the heat vulnerability index mapping, so we know which are the 5 highest cities, and we have levels 2 through 5, and we went into the 5 and 3 through 5. So with that, we did the same thing with our doulas and tried to make sure that we recruit doulas in those areas that were most vulnerable for heat. Our training system, because it's very specific to maternal health, our training had to expand from just what's heat, what's physiologic, but it's what's maternal health. We applied for a CDC Foundation disaster preparedness grant. So we were funded to be able to bring this education, turn doulas into climate educators, but then extend to disaster prep. we're in hurricane territory. We got lots of flooding. We get those rain bombs and there's flooding all the time, especially in these areas, and of course, heat. So we looked at the three most vulnerable things for our community, which is heat and flooding, and see how we can get a disaster prep. So our first thing is, if we're going to train our doulas, what are the most important things they need to know about? What are the tools? So we combined 3 tools that are already there. The CDC Chilled Out, which assesses your heat risk. Then the Pregnancy Risk Assessment Monitoring, which assesses your disaster preparation. And then we use the FEMA Flood Map, which would then have the doulas be able to identify the flooding in the areas. So we combined all 3 of those tools into one survey, which we then digitized. So the doulas would be able to ask these basic questions and score it. We assigned weight to each score. So if you never had a disaster prep, you got a 0. If you don't have air conditioning, you got a 0. If you have air conditioning, but you can't afford to pay the bill, which is quite common, you're also low. So then we would then have some responses based on that, based on where you live. If you don't have a disaster prep, you're automatically 0. And does anybody out here have a disaster prep plan? So it's very common, nobody does. So we know everybody's gonna need a disaster prep plan. So we have that scoring, and then we create an automatic release of these doulas. Doulas are not bachelor, they don't have to have bachelors to be a doula. You can be high school grad and be a doula. So our doulas range from high school all the way to PhD level in doulas. A lot of nurses are doulas, but we also have in our community just regular folks who are doulas. And we have the 3 languages, Creole speakers, Spanish speakers, so we have to really adjust everything to our level. So that's why everything has been very automatic. So we came up with what we're going to teach. How are we going to teach it? We combined our 4-hour, again, how and why is essential in understanding we had to teach these doulas, who are not all our ends, about the physiology, what goes on with pregnancy, why pregnancy is so high risk, dehydration. We taught all of that. We also taught them how to teach. And we also use America Healthy Babies. So we had a standardized teaching virtually with America, which is 4 hours, and then our 4 hours. And once they were done with those 4 hours, 8 hours, then we had them show us what they learned. Again, because these are folks who are all over, 8 hours is not really that easy to get all this material in. So when we have them make a mock video presentation as if they're with their clients, we're able to see where they are. My presentation had an example of somebody who did the 8 hours and gave it back. She didn't pass, but it was a great, great start because we then go back and fill in. We have rubrics for grading. We have lots of tools to get our doulas sufficient to the ability to go and do their clients, because we want to use this linkage that the doulas will then go back to the OBs with the information. Because it's very difficult to get any MDs to take the time. Even those things, it's really hard because you only have 10, 15 minutes. So we want our doulas to be able to say, this is what we did. This is the score your client has, our clients. Doulas do not make assessment, do not make treatment plans. All doulas do is offer support and be that agent to take information back and forth and support their clients. So they were the best person to do that with clinicians. Once we are just finishing training, and our heat season is May to October, our hurricane season is June through November, and that's when we see all the flooding. So we're gearing up to be ready for all our doulas, and we hope they'll each we're gonna monitor about 36 patients. We limit our numbers because we put money in for doulas to do this work. So they're paid when they did all their 8 hours of training. They got our grant money goes to the doulas because they're really amazing young ladies. Because Medicaid only pays for 3 visits, we added money to pay for the additional climate educator visits. So they'll get $50 for all visits they go out, especially around the emergencies that may happen. So there's money for them to do that. And there's no way we can find out your room is hot, you can't pay the bill, so we also put money in to have portable ACs for the pregnant ladies. If they are hot, we're going to try and mitigate as much as we can. We bought heat sensors so that we could monitor the internal temperatures of these homes because we know they're hot. And most of our pregnant folks in these communities really can't afford the bills. So we're going to monitor the internal temperatures. We're going to give them all the same what to do, where we're going to give them UV umbrellas and fans and everything we can to get them staying in the program for the entire year post-delivery so we can see what happens to these babies. Very ambitious plan. We've started with 20 doulas. So far, only 6 have completed the full 8 hours, the full video, and they'll be ready by March. We're trying to get 6 more over the finish line. We do a lot more one-on-one after the 8 hours, but they're so excited, and they will be certified because they're going to be Gula climate educator. Okay, you'll see Tamara, who is very excited, and she's very classic of all the doulas because they really know the heat. Most of these doulas were pregnant at some point in the same communities, and they have their stories, and so they're ready to do this. We're going to do a research, of course, and we hope to publish the data to see what we found. It's not going to be on the baby's outcome. Our goal, again, is to see how well we can train folks to learn this material and become educators and see what they do with with the education. Do they take it to advocacy? Because we also have that ability. So our goal is to see how can we turn doulas into climate educators and have them stay in our community and do the work. Thank you.
Thank you so much, Doctor. Like I said, really creative and innovative. And as somebody, I've worked with a doula once personally, and it's hard to think of any health professional I've had a closer relationship with, much more intimate and more trust in that relationship than some family members. It is a really powerful way to connect with the community and a really exciting group to get connected with. I'm just checking on time. I know that we started late, Bev. Are we able to run late too, or should I aim for that? Yeah, so we will run a little bit over. I'm not going to do all of the planned facilitated questions because I think we hit some of those subjects already, but I'll do a couple before I open up to the room and to the app for questions. Excuse me. So one of the things that I did want to ask about is kind of thinking about engaging more health professionals and really bridging this gap. Who is not at the table? Who are, I know that you're doing the work of getting those doulas connected, but kind of using that as a model of getting more creative. Who is not at the table? Who should we be doing more to connect with? And I can either hand off the mic or Dr. Malone, if you want to jump in.
Sure, I'll just make a quick statement. There are about 4.2 million nurses in the country. We don't have quite a significant number of them. So if we just could, and nurses are at every door in the healthcare system. So my goal is, while I want to make sure that it goes to everybody, all the different provider groups, I have a pretty big load to lift just in getting it spread out to more nurses and in the schools of nursing and in the hospitals. And I think the doulas are wonderful, by the way, Cheryl. And New York City, hats off to you, colleagues, for what you're doing. So I think we're all pushing in the same direction, but we've got such a long way to go.
I want the payers more in the room because where I am in Florida, they control everything between private equity and the huge companies. Everybody is employed. Most of the physicians are employed. So even if we wanted to do some of this work, the limitations on the time and the pressures on what the people who employ you do, I can't get them to say that we want to do this. New York Health, they're public and it's a little different and the doctors may have some more, but when you're in some of these systems in Florida, it is very difficult to get them. Also, other clinicians, I can't get the pharmacists, any pharmacists out here? One, perfect. it's really a push to get the pharmacists involved, again, because they're so heavily employed by the big, like the CVS and the Walgreens, and they are now struggling in the way they extract so much from them. So I think we need those people and veterinarians. It's interesting when you look at tick-borne diseases, if you follow the dogs, their rates of tick-borne infections is like 5, 10 times higher than humans, what we report. Now, you know these dogs are with humans, so it's underreporting in humans. So we need the vets to bring some of their data to show what's happening, because the dogs will show us that vector-borne disease transmission as the ranges go farther and more rapidly than us waiting on our human studies. So I really think we need much more intersection of all the health professions out here.
I would also just add to that, in a similar vector-borne disease landscape, given the current bird flu threats, we need the people that are operating food systems, natural systems, and health systems at one table. So people are at the table. We need that to be one table. And then also just on the climate education side, I think the people that have the most sort of time to spend with patients, that be doulas, community health workers, we definitely need to engage more and more, and we're working on that.
Great, thank you. I know that in the back of everyone's mind is that the federal government is the exact kind of actor that could unite across these different sectors and pull people together and have these conversations. And in the absence of that leadership, kind of how do we step into it, and how do we ask our institutions to step into it? So not an easy call to action to replace the US federal government in aggregate, but it is what it is. And I think that is something that we can all kind of go into with open eyes, that this is something that needs to happen, and be in those connections between community groups and different parts of the health sector. One more question, just as I know that all of you are good evangelists for climate change and health, and have been talking with your colleagues about this. Is there kind of a common aha moment that your colleagues have when you're working with them that kind of helps to click with them and get them on your team, out of that mode of not my problem, too big, outside of my scope, to seeing it as part of their job description?
Ben?
Absolutely, yeah.
Yeah, I just want to say it's different for different people, different groups. It's not like one place where everybody gets it. It has a lot to do with personal experiences, with things happening to family members. I've always noticed with Congress people that they don't hear anything until it happens in their family. And I think it's that not just with Congress people. I think that's how we work. We need a personal experience almost to understand things sometimes. But it doesn't mean that we don't keep doing it. We don't keep putting the information there. I always call it putting bread in the oven. We continue to put the bread in the oven. That's what we have to do. And we don't know when it's going to be done for you or for that person, but it's my job to keep putting it in there.
I like that mystery baking, yes.
I was gonna say exactly that, the personal experience and highlighting pre and post extreme weather events. We see, like, the data just shows that that's when people really change their mind, be it heat events or hurricanes, or I was actually abroad when there was a mudslide from a dramatic rainfall event. So the more sort of immediate and the more it impacts one's family, I think it's pretty clear.
Yeah. Ditto for doctors. We're in Florida, so Hurricane Ian, Hurricane Helene, Hurricane this, Hurricane that. We had 7 major hurricanes go through the Gulf in less than 10 years, 7 Category 4, 5s. That's huge. So the response, and folks are much more aware. Lower wealth communities have always experienced it. The goal is not so much the aha moment, is to say, I know it's here, but how do I act, and that I still have agency? So that's the struggle I see. So there are 2 aha moments for the population that I work with that know it's happening and have sort of resigned themselves to it. I want aha moment when they say, I really can do something. So that's my challenge. The doctors and they're getting whacked. So where we are, so they know, they just are struggling with time.
Then there's one other piece I want to add, and that's about leadership getting the aha. I think if anyone needs to get it, it's the leaders who really need to, because they can influence so many other people. I mean, how many shareholders do you have? How many wonderful people directing New York City's cool, new and hot environment? I mean, and how can we infect our colleagues? There's the whole rest of the communities that need to be infected, but boy, our leaders need to wake up and start redirecting their intention and their attention to that this is a real crisis.
Yeah, I think that my goal, if we have this same panel again next year, is one aimed at boards of directors and C-suite, is how do we get those folks fully committed and converted as well?
Yeah.
And infected, if we want to use medical terminology. All right, I'm going to open up to questions. I think most of the questions I saw in the chat were about slides and technical difficulties, so we will get those slides out. I promise. I apologize for the technical difficulties. I have my eye on these, so if folks want to put questions in the chat, please do. I think we'll go for another 5 or 10 minutes, depending on how these questions go. And if there are questions in the room, I'll just need to repeat them. Yes?
I just wanted to share an experience. I'm a hospice physician at Kaiser, and my husband passed in 2020 in a motorcycle accident, and he was a dentist at the University of Pacific Dental School. And before he passed, I was attending one of these climate conferences. I think I heard you speak, actually, Cheryl. But and he was kind of watching in the background on Zoom, and he was like saying, you know, I really wish we could bring more of this climate education to the dental community. And actually that's something that I set up in his memory at the University of Pacific Dental School, sponsoring a scholarship in his honor for a dental student that is also interested in climate change. So I think that's another group of health professionals that are trusted people that we can tap into. I mean, just imagine when you're at your dentist getting your teeth cleaned, your dentist is like talking about all sorts of different things. And that would be like a perfect atmosphere to talk about how, how does, how's it going paying all your energy bills, all this heat. And so there's so many ways to personalize this for people and make them care about it. So anyway, it's just another source of inspiration.
Thank you so much for sharing. Yeah. Any?
It those stories that like why you want to share this.
Yeah.
Hi, Steve Peterson from Washington, D.C. I had an experience last summer. We're getting warmer too, and we're coming closer to Miami. Last summer, we had 6 days over 100 degrees Fahrenheit. And on the hottest day, an elderly lady with schizophrenia came in who's on antipsychotics. And she was somebody who wanders in the community. And I think I was like a doula that day. I was able to learn more about, I had to go through all the questions and just kind of invent them. So I've written this up. Anyway, the bottom line is, where do you get your grant? And I think we could do this in psychiatry too, because we have got lots of patients on these high-risk drugs who are high risk themselves. Yeah.
This was a CDC foundation, and CDC Foundation is a nonprofit organization. They're not CDC. So they're able to give grants for this sort of, and then many of your other smaller foundations, we work with smaller foundations, your community foundations, they'll fund more of these kind of programs than when you do EPA grants that want you to monitor everything and give all the data collection and not the grassroots stuff that we do. So CDC, we just got funded through Allegheny Franciscan Foundation. All the Catholic hospitals that had to turn over, all their profits are in a foundation. So if you have the Catholic hospital systems, there's a foundation that goes with them. The Catholics have a very big Pax Christi program. And because the Pope pronounced the thing, whatever it's called, what is it called? Laudato Si. Right. So Care Creation is part of it. So most of these programs have a climate justice, most of these Catholic-type organizations. So we look in those organizations for our funding for our grassroots work. We just know the state's not going to do it. And I'm in Florida, it's illegal even to talk about climate change. So the state's not doing it, so we find those foundations that will do it. And it's not expensive, because it's $50 a visit. It's very low cost, and you can create these educators and give them a little bit of money. Our community health workers, we give $20 an hour.
Thank you. Does anyone else have a question? Yeah, I know that funding these programs is always incredibly frustrating and challenging, and especially when it's something that's such high impact relative to those costs of any community health worker program or upstream intervention like that. We know there's huge ROI at extremely low cost, but yeah.
Sorry, David Casey, New York State. Thank you, Dr. Hunter. I had a question about the survey that you undertook to understand, that heat emergencies were a priority in your area. Were you using the community health needs assessment process to do that, or how did you survey? And
Done by the county, because we had a heat officer between the Florida Department of Health at the time. We have a heat office in our county. So the heat office with University of Miami and Florida use the vulnerability index, which is based on age, level of education, hospitalizations, the zip code data. So it's done at a very high level, not at our level. And so we use their data and then built on their data set. What we overlaid on that data set were the FQACs that corresponded to the levels. And so we could identify where the FQHCs were, the Federal Qualified Health Centers, and that's how we targeted those areas. But the county did all the mapping and the data collection and identifying. The environmental justice website, before it went down, had done just that too. So it would have been very easy to find all of this across the country. I think Harvard has kept it. That's what I was told that Harvard has it.
Way back. It's called Way Back.
Yeah, it's preserved on Wayback, but also, yeah, there's also a few others that have been, preserving and duplicating a lot of those resources. But I think that we're just about out of time. But like I said at the beginning, my hope, or all of our hopes with this panel, was that people would be leaving with things that you can implement back home, whether it is, harnessing that competitive energy of institutions and nurses in particular. But I think that is true of almost all medical professionals. There is a level of intense competitiveness that can be harnessed, and being able to point either to the model of centers for excellence is something that you can achieve, or New York City Health and Hospitals actually implementing real physician engagement and activation, and then working to really get creative to engage community health workers, doulas, dentists, and pharmacists, and really thinking about how do we bridge these connections. And again, there's a wealth of existing resources, of trainings and toolkits and resources that we'll be sharing out in links throughout. And so we're absolutely excited to work with all of you. I'll stick around here if anyone wants to chat or kind of share contact information. But big thank you again to all of our speakers. I really appreciate your time, and thank you for joining us.